Good evening, Dr. Chandrasekharan. Have you joined?
Unmute.
Hello, good evening, ma'am. Yes.
Good evening, sir.
Good evening, ma'am. This is Ms. Aradhana or Dr. Sushma?
Yes, sir. So we both.
You both are okay. Great. Thank you.
Thank you, sir.
Second.
Dr. Chandrasekharan, am I audible to you? Sir?
Hello, ma'am.
Yes, sir. So before we just begin the webinar, I would like to inform you that Anil K. Gupta, sir, he's our HOD, Head of Department of ECDRM Division. And then we have with us Dr. Shushma as well, who's Assistant Professor at ECDRM Division.
So we have been in touch. We wanted to introduce you to Dr. Anil Gupta, who is the professor of our division. So, Dr. Gupta, Dr. Chandrasekharan.
Hello, Dr. Chandrasekharan. Thanks and welcome to this forum. Nice to see you.
Thank you, sir. Unmuted. Okay. So, how are you, sir? We have another 5 minutes, it seems.
Yes.
Okay. Okay. Yeah, I'm unmuted.
Dr. Chandrasekharan. Yeah, what is your native place?
Sir, I'm from Kerala.
Okay.
I was I settled in Bombay for a while, for a few years before moving into Abu Dhabi.
Okay.
Yeah, I'm basically from Kerala.
Where in Kerala?
Sir, I'm from Alleppey.
Okay.
The place called Venice of the East.
But you must be a Tamil.
No, I speak Malayalam.
Okay. Yeah, because I actually, because of this Chandrasekharan title, I thought that you are Tamil.
Yeah. We have.
Because one of my gurus in disaster management, she was earlier with Ministry of Environment and Forest, Dr. Indrani Chandrasekharan. So she her title is also Chandrasekharan.
Yeah. In the north it is Chandrasekhar.
Yes.
But here we have some suffix. We always add an.
Yes.
Yeah.
But anyway, nice to connect to you, and then we'll be learning a lot from you also. Yeah.
Oh, you too, sir.
Yeah.
Actually, I was in touch with Dr. Sushma, and I heard about the programs. Actually, I was not quite familiar with the NIDM, but I came to know that you're doing a lot of activities to uplift our safety and other measures in the country. So happy to hear about it. Yeah. So the NIDM is in Delhi.
Yes, sir.
Yeah, NIDM has 2 campuses.
Okay.
Primarily it was in Delhi. Now we have another campus in Vijayawada.
Okay,
the new capital, new Andhra.
Oh yeah. I know. I was in Visakhapatnam. I was posted to Visakhapatnam for around 6 years.
Okay. When, what?
I was there from 96 to 2002.
Okay, long back. Yeah.
Long back.
Yeah.
When I was young and energetic.
No, you are still energetic and young.
Trying to. Pretending to.
No. So, then Visakhapatnam also I had a friend. Incidentally, his name is also Chandrasekhar Verma. Not Chandrasekhar, but Chandrasekhar Verma. He was the joint chief inspector of factories.
Okay, great.
Now he is the chief inspector of factories in Andhra.
Okay, oh great. So how's the campus going? This is a new campus in Vijayawada?
Yeah, new campus under construction. Actually, the construction is not yet over.
Okay,
the structure is there now. The furnishing is going on, so it may take a year or so to make it functional. Yeah. And then we are looking for some faculty also. We are taking some faculty position also, so that we can have our people there.
Okay, great. So, sir, NIDM is a government institution, right?
Yeah, NIDM is yes. We are a statutory body of Government of India, and basically we are a think tank which is mandated for disaster management activities within India and in the region, basically. So in the region. So we have a lot of cooperation with the international agencies also, and we are always open to collaborate. We work. ADPC also collaborates with us. UN agencies, they work with us.
Excellent. I have heard about NDRF and some other agencies, but NIDM was something new for me.
Three. You can say 3 sisters: NDMA, NIDM, and NDRF. All 3 are under the same legislation.
Okay, they are all under Home Ministry, right?
Yeah, basically
so NDRF looks after the response part, and NIDM for education and training, and the third one you said.
And third one is policy, basically National Disaster Management Authority.
Okay.
So they are kind of apex body for policy making kind of things, policy guidelines, all this.
Okay,
NDRF are the field people. Basically, they go in the field, they rescue. Yeah, all that.
Okay, great. Yeah, I think we have the same system in the US. There is also one body for development of the policies and enforcing them, other body for monitoring the compliance and all. So I think it's a similar system. Oh, that's
almost. Yeah.
Okay. I was in. Sorry, Dr. Sushma. Apologies. I think you were going to say something, and then we kept on talking. Very sorry. Go ahead, please.
Dr. Sushma, from my side also. Yeah.
No, sir, that's perfectly fine. So I was just wondering if we can just start the session.
Yeah.
All
yes. Please start. Actually, I thought that Mr. Bindal is also joining. No.
Sir, I think he is gone somewhere because I just spoke to him 15 minutes back. So he says he's somewhere in the market or somewhere.
Okay. I thought that he's joining. That's why I thought that let us enjoy conversation. Anyway, so over to you.
Yes, sir. Ma'am, am I audible?
Yes,
Aradhana. Yes.
Okay. A very good evening and welcome to the webinar on environmental, non-clinical risk and disaster management in health sector. This webinar is organized by National Institute of Disaster Management. Firstly, I would like to welcome our Executive Director, Major General Manoj Kumar Bindal of NIDM. I would also like to welcome Professor Anil K. Gupta, ECDRM Division Head, NIDM. So we welcome you to our webinar. For this webinar session, the guest lecturer we have is Dr. Chandrasekharan, Risk Officer, Occupational Safety and Health System. And the coordinator for the webinar, we have Dr. Sushma Guleria, Assistant Professor from NIDM. I would like to welcome the entire panelists as well as the participants who has joined with us from multidisciplinary background. Moving ahead with the session, we have with us Professor Anil Gupta, formerly Head Director, Institute of Environment and Development Studies, University, Jhansi, since 2002. He joined NIDM in 2006, a disaster mitigation and crisis management professional, PhD in 1995, postdoctorate CSIR NIRI 1996. He possesses interdisciplinary expertise with institutional development, administration and management, coordinated several international and national projects, and has over 100 publications, including 10 books and 45 papers. He has also guided various PhD scholars. Sir, we are very privileged to have you for this inaugural session.
Thank you. Thank you, Aradhana. We are very happy to welcome our distinguished speaker of the day, Dr. Salman Chandrasekharan. And in fact, I must thank and compliment Dr. Sushma Guleria for being able to bring him to this forum, and his enriched experience within India and also in the developed world, in US and a number of countries, as he has been working on different dimensions of safety, occupational health and disaster risk management. So it would be really a great learning experience for all of us to discuss on a very important topic that has in fact emerged as an imminent issue witnessed by the coronavirus pandemic past 10 months or so. Recently, what kind of a new trend that we all are witnessing, the trend is of environment-related disasters. For example, in India, we have a list of 33 kind of disasters, including hydrometeorological disasters like floods, drought, cyclones and all. Then geological disasters like earthquake, tsunami, landslides and all. Industrial chemical disasters, accidents, so on and so forth. But very recently, past 10 or I would say that 1.5 decades, so 15 years or so, we are witnessing a number of complex emergencies more often as compared to the previous times. Now, in fact, very recently, just last year only, we had to declare health emergency because of a very high level of air pollution. So episodic issues are episodes of pollution related with atmospheric pollution. Then we also had some kind of emergency events related with the waste dump yards and some kind of damage to life and property has also been reported. And certainly the damage to environment is already included in the definition of disasters in the India's Disaster Management Act. Besides this, NIDM is currently engaged in supporting the Government of India in developing its National Crisis Management Plan for sudden contamination of water bodies. So we are also looking for these kind of risks, that what will happen if the water supply system suddenly gets contaminated because of either a sabotage or any technical error. So intentional, unintentional, or any kind of thing, maybe chemical contaminant or a biological contaminant. And in India, like we have a lot of events where billions of people take holy dip in the river within hours of time, and if something happens to water quality, what will happen to people's life and their health. So these kind of issues. Then very recently we had faced a major pest attack, like locust attack, that was of the scale of a disaster. So why I am referring to these, that these are new kind of disasters which were never included as within the list of disasters. In fact, 2015 only we included heat wave. Dr. Sushma supported me, and she authored a book based on our documentation study on heat wave, because earlier we never included heat wave as a major disaster. It was yes, it was a concern, and we were able to manage. But 2015 onwards, we are dealing it as one of the disasters. So now these kind of environmental issues are climatic kind of extremes are presenting us new form of disasters. Then I often say that this past 10 months, we all are so much surrounded by the electronic gadgets on our head. Before, in front of us, like on my head, there is an electronic gadget. In front of me, there is a computer. And so we all are surrounded by so much of electronic material, and this is going to generate a lot of electronic waste. So probably dealing with electronic waste is going to be of the scale of a disaster, because that is going to be a very, very serious issue. So new dimensions in disasters, new kind of toxicities, exposure to even microwave radiations, exposure to harmful kind of a radioactive radiations. Like in Delhi few years back, we had faced and some people lost their life because of the radioactive material exposure in the waste improperly disposed from a laboratory. So these kind of things are emerging as major challenges, and that is the reason now I often say that for quite a long time we were referring for environment as a victim.
So, I'm sure there's some technical glitch.
He'll join, I think. It must be some net issue. Maybe.
Yes, ma'am.
Just a while. So just to, for all the participants, most of you must be aware that Bhopal gas tragedy has been one of the, major chemical incidents that the country remembers. And despite the fact that it happened way back in 1984.
This kind of disasters,
Yes,
natural and man-made both. On the other hand, whenever a disaster strikes, it is also leading to huge amount of waste. That waste may include even hazardous waste also, a kind of a white goods also. So that is another dimensions of environmental impact of disasters. And that is why in India we are talking that a disaster damage assessment or the post-disaster need assessment should include environment as a sector. And beside this, the new streams globally that has evolved are of ecosystem approach to disaster risk reduction. And recently, the International Union for Conservation of Nature has released the standards for nature-based solutions. So we are also looking at that how disasters can be reduced, our disaster intensity can be reduced by the ecological interventions. But on the other hand, how natural and man-made disasters, their impact on ecosystem and environmental quality, environmental services can be reduced. And this is very important from the point of view of the protection of the human health, not only human health, health of the livestock, health of the wildlife, health of the all animals, because we live in an environment where all are related, and this relationship we understand as ecology. So ecology, environmental health, these are very important dimensions. And in fact, this past 10 months of experience globally, this coronavirus pandemic has given us a great lesson that we need to understand the need of a harmony, and we need to understand that probably protecting health, and particularly the environmental health, and with the concept of a new approach of understanding of the holistic health concept, that is very, very important. And just before I close my opening address, I would like to inform that NIDM has also recently contributed a national health adaptation plan under the National Mission on Climate Change to see that how the climate-induced health risk, climate-induced disaster risk and associated health implications can be reduced, so that we can safeguard and we can reduce the mortality and morbidity of human beings. So with this, I welcome the expert speaker of the day, and I must compliment once again the team which organized this program, Dr. Sushma Guleria and Aradhana, for this, and I welcome all the participants on behalf of NIDM. Over to you, Dr. Sushma and Aradhana. Thank you.
Thank you so much, sir. Thank you for providing a backdrop and a background for the webinar session. Moving ahead with the session, before I invite the speakers, I will be highlighting few objectives of the webinar. The very first objective of this webinar is to understand how environmental, non-clinical risk and disaster management in health sector can play an important role. Also to get an insight about national and international level initiatives in contributions to existing programs, frameworks related to disaster management, also including the Sentai framework and the Sustainable Development Goals. Our third objective is also to understand the policies related with these programs, which minimizes health risk and their associated health and other consequences. And discussions will be carried out regarding the multifaceted strategies and specific action to manage the wide range of risk of emergencies, general strengthening of countries' health rooted primarily at the healthcare center. Well, with these objectives, I would like to invite the speaker of our session. We have with us Dr. Chandrasekharan. Dr. Chandrasekharan is a veteran from Indian Navy, currently working as environmental risk and disaster management professional in health sector of Abu Dhabi government. He is an alumnus of Tata Institute of Social Science, Mumbai, and holds a doctorate from University of Atlanta, US. He is a lead auditor for 3 ISO standards and has an A-grade practitioner approved by Abu Dhabi government OSHAD. He did a certification course as an emergency management specialist from National Association of Safety Professionals USA and completed basic advanced disaster management course from European Master Disaster Medicine Academy, Italy. He did his doctoral research on factors affecting implementation of occupational health and safety management in health sector of Abu Dhabi. He is involved in charitable and social activities in close collaboration with Indian Social Center. Sir, we are very honored and very privileged to have you for this webinar session. Over to you, sir.
Thank you, Ms. Aradhana.
Yes, sir.
I hope all of you can hear me. Can you all hear me?
Yes, sir. You are audible.
Okay, okay.
Shall I share the people? So
sorry. Namaste, everyone. Thank you, NIDM, for giving me this opportunity. It is indeed an honor and a privilege to speak on a platform hosted by the National Institute of Disaster Management. Thank you, Professor Anil sir, for the opening session. It was really insightful and enlightening. Thank you, Dr. Sushma and Ms. Aradhana, for coordinating and all your support and hard work. It has been a pleasure working with a committed bunch of professionals of the NIDM. Ladies and gentlemen, I can't see how many are here. But anyway, thank you for coming in. Thank you for your interest. I hope I'll be able to add some new knowledge, or I'll be able to add value. As we all know, the world is going through unprecedented times. The pandemic has put the world or thrown the world out of gear, and many countries are still struggling to cope with. Many industries have come to a standstill, like the travel and tourism have come to a standstill. while some other industries like healthcare were expected to double or triple their capacity. Many employers worldwide have allowed their employees to work from home, while the frontline workers like the police or the military or the healthcare workers, they were expected to march to a different drumbeat. We also hear about a lot of updates. We get updates from the world almost every day. We heard about a critical care nurse in Italy who had to unplug the life-saving device from one of her patients to plug it on another patient who had a better chance of survival. And this is exactly what happens when you do disaster triage. She was in tears because that patient died, but she was helpless. This is exactly what happens. Now, this could not be prevented because she ran out of resources. She had to do this. But there are many other preventable incidents happening around. We heard about collapse of a COVID quarantine building in China, killing around 29 people. A similar incident happened in Russia, killing around 5 people. Another facility in Qatar, a COVID screening facility in Qatar, COVID care center in Qatar collapsed, and around 26 healthcare workers were injured. We had a fire in one of the COVID quarantine center in India, killing around 5 people. Also, recently we had another fire in a non-COVID care facility, killing around 10 neonates. Now, the thing is, most of these incidents were preventable. And I think the topic that we're going to discuss today, risk management and disaster management in health sector, this is an answer. We need to be more proactive. So, ladies and gentlemen, I'm going to present my PowerPoint presentation. I have made some slides for you. Sorry, I'm not very familiar with this WebEx program. I'll try to share my screen. Ms. Aradhana, you can help me, please.
Yes.
Okay, I'll try to share. Okay, my screen. This is how I go. My daughter is here to help me. Thank you. Okay, are you able to see my screen?
Yes, sir. Just go through.
I'll play the slideshow from the beginning. All right.
Yes, sir. Yes.
Okay, are you able to see this?
All clear.
Okay, thank you. So, ladies and gentlemen, these are our learning objectives, and by the end of this session, we expect you to have a basic understanding of environmental or non-clinical risk management in healthcare. As you know, in healthcare, there are different types of risk. You will find clinical risks which are related to patient care, like the medication issues or other errors. But there are also non-clinical errors. So today we are going to cover non-clinical errors or non-clinical risks only. So we'll talk about some of the common environmental hazards. We'll talk about 3 lines of defense in risk management, the risk management process, the steps in risk management. We'll also talk about the emergency and disaster management in healthcare. We'll discuss about the 4 phases of disaster management, like mitigation, preparedness, response, and recovery, how it is applied in the health sector. We'll also discuss about the hospital incident command system, which is a very robust system developed and used in most of the developing countries. We'll also talk about the business impact analysis and the business continuity plan. And I'll also give you a quick overview of the regulatory requirements, like especially the OSHA program here in the Emirate of Abu Dhabi. I'm glad to acknowledge the fact that most of the learning that I'm going to share with you today, I gained it from my first employer, the pride of the nation, the Indian Navy, and also my counterparts from other services, the Army and Air Force, and here, my current employer, Tawam Hospital, and the government of Abu Dhabi. With the OSHA program, it's a very robust program, one of the bold, most ambitious program, which is limited to the Emirate of Abu Dhabi, and I thank the leaders of this beautiful country for this initiative. So we will begin the session here. Now, when we talk about risk management, it is very important to understand the difference between hazard and risk. Although we use these terms quite synonymously, there is a difference between hazard and risk. So hazard is anything that has a potential to cause harm, and the risk is the probability of something bad happening. Now, why we need to understand the difference between hazard and risk? When we talk about risk, or when we tell our management that the risk that I have identified qualifies to be an extreme risk, high, moderate, or low risk, and they might have limited budget, then when we prioritize, we have to tell them why we came to that conclusion and say that the X is a high risk or an extreme risk. It is actually sometimes difficult. Let me give an example. An exposed electrical wire or a poorly managed electrical wire. Okay, that is the hazard. And what is the risk? There can be many risks with that hazard. It can cause electrocution, someone can die of it. It can cause a fire. It can also cause damage to your equipment that it is connected to. Okay, so there are 3 risks related to this particular hazard. Now, 2 of them might qualify to be extreme risks, like risk of electrocution and the risk of a fire. These might qualify to be extreme risk. While the third one, the equipment damage, could qualify to be a moderate risk, depending on the type of equipment that it is connected to. So it's very important to understand. Now, you look at the picture here, you have a cigarette, we see the cigarette here. Cigarette is a hazard, and what is the risk? It can cause lung cancer if you're a smoker. A camel on the UAE road or a kangaroo on the Australian road is a hazard. And what is the risk? It can cause accident, or professionally we say it can cause personal injury and property damage. Risk management is therefore a program for prevention, monitoring, and control of potential hazards and unsafe work practices. The purpose or the objective of these programs generally is to improve the quality and safety of care by minimizing injuries, preventing loss, and complying with the standards. I need to repeat: minimizing loss, preventing injuries, and complying with the standards. These are the objectives. Now, how do we comply with the standards? Yes, understand what the laws and regulations or the requirements or the accreditation requirements are, develop your policies and programs, you implement them, ensure that the people adhere to them, right? This is how you ensure compliance to a legal or accreditation requirement. Now, how do we minimize loss? You minimize loss by safeguarding your assets. For that, you need to understand your assets. What are the assets? Generally, the assets or the resources of any organization are characterized by 5 M's: men, material, money, machine, method, right? But in health sector, we need to look at other assets like the operational continuity, because the people will be depending on a hospital. When they come to the hospital, they think that yes, everything will be taken care of. And if we are not ready, or if our business is interrupted, there is an issue, right? So in the health sector, we don't go by the 5 M's generally. We talk about people, property, reputation, information, and operational continuity. I need to repeat. When we talk about assets or safeguarding our resources or assets in organization, in the hospital, we talk about safeguarding the people, which means our patients, staff, visitors, everybody, the contractors. So people, property means the infrastructure or your equipment. Reputation of the hospital, is it important? Yes, very important. People, property, reputation, information, especially the health information, very, very important. And operational continuity. Okay, so these are the 5 assets that we focus on when we talk about environmental risk management in health sector. Now let's discuss about some of the common hazards that you find in health sectors. The first one relates to the safety of physical facilities. It could be as simple as a slippery bathroom in a patient room, causing a patient or a visitor to fall down. It could be an unprotected or unguarded balcony that might allow a patient to fall down or commit suicide. Could be the collapse of a ceiling or a hospital building itself or alternate care site. So what are our prevention strategies? We have a lot of prevention strategies. We have proactive risk assessment, audits and inspections, incident investigation, which is reactive, then complaints, your SNAP inspection surveys, then GCA tracer, Joint Commission tracer, or NIDM tracer. So there are many ways to identify and prevent the risks. Now, another thing that I'm going to emphasize today is development of policies to ensure that all stakeholders are on the same page. This is very, very important. Now, during the pandemic, being one of the largest healthcare provider here in the government sector, we were actually involved with the military and the local bodies here to set up screening tents and alternate care sites across the city. We have set up many tents and many alternate care facilities. The first thing that we have done before proceeding with setting up tents was developing a policy on a policy titled General Safety Measures in the COVID screening tents and alternate care facilities. So there, in our policy, we addressed that, yes, you might have a tent, but the tent must withstand a wind velocity of 100 km/h. So because we didn't want our tent to collapse, because most of our tents were in the open area. We mandated that the contractor, when they use a material to make the tent, they use material which are fire resistant. The policy also addressed many issues like the no smoking in and around the tent, security patrol, many other provision for hand wash and all other hand hygiene and other stuff. So my point here is it is very important to develop policies and have a documented process to ensure that all your stakeholders are on the same page. Another hazard that you could think of in healthcare relates to the hazardous material. We live in a pool of hazards. In healthcare, we live in a pool of hazards. We have chemicals, we have biohazards, carcinogens, corrosive, irritants, and a number of hazards. You might have radioactive or chemo spill in the area. You deal with compressed gas a lot. You might have liquid oxygen tank. The liquid oxygen tank, you must ensure that there is a safety valve because it's a compressed gas. And one of the requirements is that it must be away from common areas, at least 15 meters. It should be at least 15 meters away from common areas. You might have liquid nitrogen in the IVF center. If you have an IVF center, you might have cryopreserved embryos. And the cryopreserved embryos are generally stored in liquid nitrogen tank. And the temperature is generally minus 180 degrees centigrade, right? So you might have a cold burn if there is an exposure. And IVF, the liquid nitrogen, it is not a flammable gas, but it is an asphyxiant. What does that mean? If there is a leak, your room will have less oxygen. So you may have to have alarm system to warn you when the oxygen saturation in the room goes below 19%. So these are some of the prevention strategies. Yes, you have PPGs, Policy Program and Guidelines for Safe Storage, Handling and Disposal. You might have staff training and competencies. Management of change. This is very, very important. What does management of change mean? Whenever you add a new process or an activity or you bring in a new equipment to your area, you do a proactive assessment to ensure that nothing goes wrong. There was an incident in one of the facilities I heard where in the laboratory they brought a new equipment without considering the power load, and there was an explosion in their DB, distribution board, electrical distribution board, because the power was not considered, power load was not considered. So this is very important. Management of change is very, very important. Another hazard in health sector could be fire safety or relates to fire safety. Could be overloaded or poorly maintained circuits. The patients or the visitors plugging in 2-pin plugs into 3-pin sockets. Now this is a very, very common issue. You might have people use mobile phones and other devices, and it is very likely that they come with a 2-pin plug and they try to plug it in the 3-pin, so it may not enter. So they use some the pen or scissors or whatever they have. They plug it in there, and it might cause a short circuit or a fire. So there are many risks associated with it. Violation to no smoking policy, because this is an issue with the health sector. You have people from different areas and they come with different knowledge and understanding and different level of compliance. So they might be smoking and you are at risk because you have maybe oxygen enriched, because you have a oxygen enriched environment. There are challenges with early warning and suppression system, your smoke detectors, your fire sprinkler system, etc. So what are our prevention strategies? You will have fire risk assessment. It is very important to conduct the fire risk assessment before you start, especially if you have any construction or renovation in a hospital. You need to do fire risk assessment. Now, even Joint Commission mandates that you do a PCRA, pre-construction risk assessment. PCRA, then prevention, before, during, and after construction, you need to do the risk assessment. So you will have, and you will have staff training on fire safety. You will tell the staff about the fire triangle, the difference, like the heat, oxygen, and fuel. If they meet, there will be a fire, and if you eliminate any one of them, there won't be a fire. You will have planned preventive maintenance. You will have fire warden and safety link program. This is very important. Fire warden and safety link program. They are going to be your eyes and ears in the hospital. I conduct workshops to train the potential safety links and fire wardens. And I found this program very useful, because what happens is in a hospital, you may not be able to, like a risk manager or you may, or the health and safety professional may not be able to ensure safety in the hospital, because you do your audits, you do your inspection, but most of them are like random. When you go to a patient care area, the patient care area may be engaged. Patient might have privacy reasons, and you may not be able to enter the room. But if you train a nursing staff or a technician working in that area, they may be able to go there and check the issues. And our safety links have brought up many issues, like a leak in the bedhead unit, because the patients have just above the patient bed, you will find bedhead unit which has oxygen, vacuum, and all the supply. Sometimes the oxygen leaks and you may not know, but your safety link or your fire warden in the unit can identify this and tell you. So it is very important to have fire warden and safety link program. If you have a good, robust safety link program, most of your issues will be under control. You will also have policies mandating storage of items which 45 centimeters away from the ceiling. The requirement is that no item should be piled up to hit the roof or the ceiling. It should have a gap of at least 45 centimeters. And the reason is your sprinkler system won't be effective if items are too close to the ceiling. You may have a sprinkler system in some areas and you may not have in other areas, but it is always good to be consistent. Keeping workplace free of combustibles. And you will also be conducting fire drills. So these are some of the prevention strategies. Now, it's a very interesting story that I want to tell you. I get involved, being an OSHA certified auditor and a certified investigator. I come across many incidents. I lead root cause analysis and incident investigations. We share incidents and we learn, the lessons learned from incidents with our counterparts from other facilities. So this was a lesson that I thought would be of interest to you. Airway fire. Although it happens rarely, it is important to understand. One thing that we need to understand is most professionals in healthcare, the physicians or the nurses, they join this profession out of their passion to serve. Okay, and they are humane. What happened in this incident was there was a patient who had some issues with the insurance, and the patient was paying out of pocket. So when the patient told the surgeon that I have this insurance problem, the doctor went out of his way to help him. And sometimes these kind of helping it also backfires. So what happened was the patient was to go for a tracheostomy. This surgeon was well experienced, and during the surgery, sometimes to stop the bleeding, the surgeons do a procedure called electrocautery, which means burning the tissue in the trachea by causing a spark with a laser. Okay, with the use of laser. So during this procedure, and there are chances of airway fire. So what happened was this picture that you see here, it is for illustrative purpose. This is not the actual, not from the actual incident, but there was a fire in the patient's trachea. Now the endotracheal tube, which the patient was connected to, that also caught fire, and there was fire in the nearby equipments. The response was very good. The team, the respiratory therapist who was there, immediately detached the endotracheal tube from the patient, and the fire was extinguished by the security. It was a big issue. Around 10 patients from that area was evacuated. 10 rooms were evacuated. So it was a big issue. But the security used the appropriate extinguisher, and it was extinguished. And somebody went to the centralized oxygen valve area and turned off the oxygen, because oxygen is flammable. So two lessons that we learned, or that they learned, that the organization learned from that incident, was that is doing cautery in the oxygen-enriched environment, because this surgery to help the patient, instead of OR, it was done outside. In that oxygen-enriched environment, that shouldn't have been done. Another thing was that this person turned off the centralized oxygen valve without consulting the team leader. Now, when you turn off the centralized oxygen valve and you have 30 or 40 patients dependent on oxygen, you will be jeopardizing the safety of everyone. Okay, so whenever you turn off such centralized oxygen valves, ensure that your team leader is consulted. Another hazard in healthcare relates to safety of equipment. You might have new equipments, you might have new staff, you might also have equipments due for planned preventive maintenance. For example, during Corona, you may not have enough technicians at work, you may not have enough biomedical engineers. So there may be items which are due for planned preventive maintenance, or you also might have equipment which are due for replacement. So what are our prevention strategies? You have planned preventive maintenance. You will also have management of change. Whenever you bring in a new equipment, you will do your risk assessment, proactive risk assessment. You'll also have staff training and competencies. Now, another thing that I would like to emphasize here is risk communication. I would like to bring to your attention about another incident, about an incident in MRI department. What happened was, there was an organization where this MRI was used, and they had a ventilator which was MRI friendly, and the ventilator had a label that it was MRI friendly. But for almost 10 years, this ventilator was not used in the MRI because they had another equipment with the same capability. They had an anesthesia machine which had the ventilator capabilities. So what they did is they, just to save the resources, they moved this ventilator to another area, and that was used in that particular area for almost 10 years. But one fine morning, the surgeon in that area had a chat with his counterpart in another facility, and they said, oh, we are using this equipment, this ventilator, why you are not using? So this surgeon thought, okay, why not to use it? So they brought that equipment back and used it in the MRI center. Now, this equipment had a label that it was MRI friendly, right? It was compatible. The MRI procedure was almost over, and the respiratory therapist was actually maneuvering the ventilator, and while she was coming out, the ventilator got attracted to the MRI machine. And now it suddenly got pulled, and the MRI, most of them have a capacity like of 1.5 to 3 Tesla. 1.5 to 3 Tesla is the magnetic power of the MRI, which means it is almost 40,000 to 50,000 times of Earth's magnetic power. This is the power of the MRI. So what happened? This ventilator got pulled towards the MRI machine, and it got stuck there. There was no injury. The patient was already out. Okay. Now this ventilator got attached. The therapist who was there, she screamed, and the people, around 4 or 5 people, went inside to help her out. They tried to pull this ventilator out, but it didn't come out. After struggling for around 15 minutes, some parts of the ventilator got detached, and it came, but the battery part of it got drifted towards the center or the core of the MRI. Now, during the investigation, it was revealed that since this ventilator was out of the MRI for quite some time, during one of the PPM, during one of the planned preventive maintenance, the biomedical engineers, they replaced the battery, the MRI compatible battery, with a ferromagnetic battery. Because for them, yes, it was never used in MRI, and they assumed that it will never be used. So that message was not communicated. Okay, so that was the lesson learned. Now, this is very important. When you do any change, you communicate it with your stakeholders. They may not be aware. There are issues about the safety of the respondents. Now, JCI or Joint Commission mandates that you have a list of your hazardous material in your area. The purpose is, whenever you have an external respondent coming to your facility, they should be able to identify, they should know what the hazards are in your area. So if somebody comes with a fire extinguisher to your MRI, he should know that he should be aware of the risks associated with it. So it's very important to communicate the risk. Another hazards relate to safety of utilities like electricity and water. The issues could be standby power for life-saving equipment, battery backup during transport or evacuation, extended period of power failure, example, a flood that may force you to evacuate. Now, what are your prevention strategies? You need to do the power load assessment in megawatt. You know what? This is very important. Your normal power load of the hospital might be around 5 or 6 megawatt. But during a crisis, you don't have enough power. Then your supplier or your local provider might try to help you. They might bring in portable generators, and you might have only 1 or 2 megawatt. It is not sufficient to run your whole organization, your whole hospital. So you need to prioritize. Then you have to say, okay, I need it only for my ICU building or my operation theater building. But this needs to be planned before. You need to do a risk assessment based on your acuity, and you need to prioritize. And this zone-wise plan, including the drawing, needs to be communicated to your communicated with your stakeholders. Only then you will be able to do this. You also might have business continuity plans. We are going to talk about business continuity plan in a while. You will also have load test and off-load test for generators, and you will also have planned preventive maintenance program. It is very important to conduct drill with your local service provider. There was an incident in one of the facilities where there was a power failure in the angiography. The power failure happened around 10 a.m. while there was a patient, and the procedure was almost 90%. So the patient was not harmed, but the power restoration took around 6 hours. You know why? What happened? On the previous night, somebody was working and they had a small thing to fix, and they thought they will fix it around 10 o'clock in the morning because they were expecting some supplies. At around 10 o'clock in the morning, they had to, in fact, change a cable. So they brought the cable, they started doing the work, but when they did it, they realized that the cable fell short by around 10-12 inches. So they had to get another cable. Now, getting another cable took time. Also, they got another generator, portable generator, but the portable generator could not be connected. It's a big generator, not the small ones. It could not be connected because the feeding area and the receiving area did not match. It is very, very important to conduct drills with your suppliers. Only then you will be able to identify the gaps. So that was a quick brief about some of the hazards in health sector. There are so many. We conduct workshops and we can have maybe more sessions in future to talk about the risks. But just to give you an overview. Now we will talk about the risk management process. There are 5 steps in risk management. They are: establish the context, identify the risk, analyze, evaluate, and treat the risk. And communication and consultation, this will be ongoing in all these stages. Then you will have your monitoring and review program. Now, the first step in risk management is establish the context. What do you mean by this? Establish the context means you understand the external and internal challenges in that area, or you understand the situation that you are studying well. Now, sometimes your hazard and risk might be the same, but depending on the context, the rating might vary. For example, you have a tear in the carpet in your lecture hall, and you have a tear in the carpet, the same hazard in the rehabilitation center. Which one would you treat first? You will definitely treat the one in your rehabilitation center, because in rehabilitation center, you might have patients with walking aids or physical disability. So if someone falls down there, the injury will be more severe. But in the lecture hall, you will expect healthy people, right? So even if someone falls down, nothing much is going to happen, right? So you will say that a tear in the carpet in rehabilitation center is an extreme or high risk, and a tear in the carpet in lecture hall is a low or moderate risk. This is what you will say, right? A risk of fire in the operation theater and a risk of fire in your casualty department are different scenarios. A risk of fire in your intensive care unit and a risk of fire in your outpatient department, the context are different, and so your preparation, your evacuation preparations, they all need to be different. Hope you're getting me. Okay, so this is very important. You understand the situation before you do your risk assessment. Then you identify the risk. How will you identify the risk? Identify the risk basically means to see who will be affected, how will be affected, and what can go wrong. And there are many ways to identify the risk. You can do your inspection, your SNAP audits, your risk assessments, incident investigations, complaints. So there are many ways to identify the risk. Your tracers, JCIA or NABH tracers. So there are many ways to identify the risk. Now, once you identify the risk, then you will analyze to see what is the probability and the consequence. What is the likelihood of an incident happening and what is the consequence if an incident happens. Then you will evaluate to say that if it is whether it is an extreme, high, moderate or low risk, and then you will treat. Okay, I will talk about risk analysis and risk evaluation using a tool called risk matrix. This is the matrix mandated by the OSHA here, the OSHA regulatory authority here. So this is a risk matrix. It has two components, basically, probability and consequence. Probability is the chance of an incident happening, and the consequence is the severity if it happens. Let's talk about these two examples. A tear in the carpet, very simple to understand. A tear in the carpet in your lecture hall and a tear in the carpet in your rehabilitation center. Let's look at the probability of this incident happening. The probability is classified into 5: rare, possible, likely, often, or frequent, or almost certain. Which means almost certain means you will have incidents every day, because this will depend on the usage. Often means you might have an incident 5 to 12 times per year. So this is how it goes. The consequence is classified into insignificant injury, like minor injury, moderate injury, major injury, or catastrophic injury. So let us do the risk rating of this hazard. You have a tear in the carpet in rehabilitation center. What is the chance of someone falling? It depends on the usage. Maybe if your rehabilitation center is crowded and you have patients every day, you might have a fall every day. Okay, which will qualify. You'll make it qualify to be almost certain. Okay. Now this is an assumption, and you won't get a clear answer. So it will fall somewhere between 4 and 5, like maybe 4 or 5. What is the chance? What is the consequence if a patient falls down there? In rehabilitation center, your patients may be on walking aids or with physical disabilities. So you will think that if a patient falls down, he might sustain a hip fracture or a serious injury. So you will call it maybe like a major injury. You'll consider it to be a major injury. Then you can multiply. You will multiply 4 into 4 or 5 into 4. You will get either 16 or 20. So you will be somewhere in the red shaded area, which means your risk rating will say that a tear in the carpet in rehabilitation center is an extreme risk. And as per our policy, extreme risk needs to be addressed within 24 hours. Okay. Now the same hazard and risk, you have a tear in the carpet in your lecture hall, and look at the probability and the consequence of that incident. Again, it depends on the usage. Now our lecture halls are not used because of Corona, so the possibility of someone falling may be 2 or 3. Okay, so we will say maybe it will be likely, maybe 3. And what if somebody falls down? The people there are healthy. What if I fall in the lecture hall, or one of you fall in the lecture hall? Maybe you will sustain a minor injury, like an ankle sprain or something. Okay, so you will again multiply 3 by 6, 3 by 2, and you will get 6. And it will be somewhere in the yellow shaded area. And yellow shaded area represents moderate risk. So what you will say eventually is that a tear in the carpet in rehabilitation center qualifies to be an extreme risk, and a tear in the carpet in lecture hall qualifies to be a moderate risk. Okay, so this is how you come to that conclusion, and you will convince the senior management. Now you analyze the risk. You need to control. Now you need to ensure that you treat the risk. How will you treat the risk? There are many ways to treat the risk, and this is the hierarchy of risk control: elimination, substitution, engineering control, administrative control, and procedure and PPEs. Now, risk elimination is the most effective way, and PPE is the last resort. Why? Because if your PPE fails, nothing can save you. Now, it was actually very difficult to explain this before, but now with the Corona, everyone understands. Risk elimination is the best way. Now, you sit at home, so you won't get the infection. But if you wear PPE and go out, there are chances of infection, right? So this is how the hierarchy goes. So what does risk elimination mean? We have done a risk assessment of all our meetings rooms to ensure that our COVID protocols are in place, and we posted this this picture in our in the doors of on the doors of our meeting rooms. So it talks about risk elimination. They explore video conferencing or teleconferencing. So don't come to the meeting room if you can do video conferencing. Substitution, hold meeting in open areas. Engineering controls, have physical barrier if possible, have 4 to 6 air exchange per hour. Administrative controls, ensure availability of 10 cubic meter space per person. Now, this 10 cubic meter space per person, it was an OSHA requirement even before Corona. So this was actually something that we were already complying with, and it was very easy to enforce. So provision for hand hygiene, respiratory hygiene, avoid touching door handles, shaking hands, wearing neckties. These are all the administrative controls. Ensuring cleaning, ensure cleaning and disinfection between users, and PPE. So this is generally, this is a typical risk control hierarchy. Now, when to undertake risk assessment? OSHA mandates that you undertake risk assessment at various times. Okay, so this includes when you plan or make changes to a work procedure, activity, or practice. When you introduce a new plant, equipment, or material or substance after an OSH incident, including near misses. When you introduce new workers to your area, including the CEO. When you have any new staff, you do the risk assessment to make sure that that person understands the new requirements. The presence of high level of risk associated with specific work activity like confined space or hot work like welding at regular or scheduled intervals appropriate to the nature of the workplace and the hazards present. When your legal requirements or legislative requirements change and before any work activity begins. So ideally, you should do a baseline risk assessment before you start any of your operation. And subsequently, you need to do risk assessment on an ongoing basis. We are all big fans and advocates of proactive risk assessment. We all like it. Sorry. But it sometimes doesn't happen. And it is very important to understand the difference between correction, corrective action, and preventive action. Let me give you an example. We all have experience with the Joint Commission surveyors or the NABH assessors or ISO auditors, right? Imagine a scenario that a Joint Commission assessor comes to your hazmat storage area, your hazardous material or chemical storage area, and identifies that you don't have enough eyewash. You have a lot of hazardous material, but you don't have enough eyewash. Because most of the MSDS, if you look at the material safety data sheet, it will tell you that you need to irrigate the eye for 15 minutes in case of a spill or exposure. And you may not have anything, or you might have hardly one bottle that would last for, the eyewash bottle, that generally lasts for 3 minutes only. But the requirement is that you irrigate the eye for 15 minutes. So what we will do, we are smart people, right? What we will do, we will quickly grab a few eyewash bottles from somewhere, fix it there in the hazmat storage area, take a photo and show it to the auditor. We will say, sir, we fixed it. Please don't mention it in the report. What he will tell you? He will tell you, my dear, I was the headmaster or the principal of the school where you studied. He will not close. And we will say, kaisa aadmi hai, right? Why? Because what you have done is correction. He cannot accept it. What he wants to see is a corrective action. Like you do an organization-wide assessment of all your hazardous material storage area. You need to list down all your hazmat areas, identify, go through the MSDS of each, and then come up with an action plan, organization-wide action plan to ensure that all your hazmat areas have permanent eyewash or eyewash bottle, depending on the recommendations in the MSDS. So that is a corrective action. So you have correction, then corrective action. And if you do this action before a surveyor identified this, then that is your preventive action. Okay, so understand the difference between correction, corrective action, and preventive action. This is an ISO terminology. Sorry, these are ISO terminologies. So who is responsible? We always say safety is everyone's responsibility. And now this is the biggest problem. When we say everyone is responsible, that also means that nobody is responsible, right? That's why it is very important to talk about the 3 lines of defense in risk management to assign responsibility. Now, the first line of defense in risk management, this is the process owner. which means the in charge of your laboratory or your radiology or your pharmacy or your radiotherapy department, the in charge of that area must be able to identify the risks proactively and manage them. Okay, if they fail, then you have a second line of defense, which are the people who oversee this program, like infection control, people from quality department, risk and safety, environmental services. They are the second line, the people who oversee. Okay, then if they also fail, there is a third line of defense, like the auditors, your internal auditors and external auditors, like Joint Commission surveyors or NABH assessors, ISO auditors, or your regulatory bodies. So these are the three lines of defense. The process owner must be able to must be educated and empowered to identify and solve this or manage these risks proactively. Okay, so that is the first line of defense. If they fail, the second line of defense, those who oversee, and if they also fail, the third line of defense, they must be able to identify this. Okay. Now, another challenge with these three lines of defense is that the first line of defense will think what I fail to recognize will be picked up by the second or third lines. So they will be casual. What will the second line of authority, line of defense will think? That our guidance must be working. The first line had no issues, so they might be doing okay. What will the third line of defense will think? Surely the gaps have been picked up by the second line. So this shouldn't happen. Okay. Each of these, three lines of this defense are responsible and accountable. Now, OSHA has a very robust program for ensuring accountability, and there is a huge roles and responsibility program. Actually, if you look at the program, it will tell you about the roles and responsibilities of the CEO. The CEO is responsible for providing leadership and vision and providing resources. The responsibility of the management representative is an ISO term. The management or MR's responsibility is to appraise the senior management about all the challenges with the compliance to the program. And the unit managers are responsible for implementing all the proactive and reactive measures in their units. They should consider health and safety whenever they make any changes in their unit. The safety links and fire warden, as they mentioned, they have a huge responsibility. They will do audits, they will do inspection in their area, they will conduct fire drills. They will be the resource person. The safety links and fire wardens will be the resource person for the safety related matters. They will ask, they can quiz the staff to check their compliance. They can ask the staff, how do you report incidents, how you report risk, how you report unsafe conditions. And all staff have their responsibility to attend the education programs, attend the training programs, attend the fire drills, report risk, report incidents, etc. The contractors also have similar responsibilities. Now, the good thing about OSHA is it makes all these jobs and all these roles and responsibilities part of the job description, okay? And it is part of their appraisal. It is part of the employee's annual appraisal. So there is no way someone can skip it. Ladies and gentlemen, now I'll give you an overview of the emergency and disaster management program. We all know the difference between emergency and disaster. Anyway, it's very important to understand the difference between emergency and disaster. What is an emergency? It's a serious, unexpected, and often dangerous situation requiring immediate action. And disaster is a sudden event that, such as an accident or a natural catastrophe, that causes great damage or loss of life. We call an emergency a disaster when it overwhelms our capacity to respond. Now, most of the emergencies, most of the emergencies likely to occur in a hospital are short duration, low intensity emergencies. Most of the hospitals have a color-coded system to deal with emergencies. There are internal and external emergencies. We call an internal emergency, like a fire or a hazmat spill, a disaster when our survival without external help becomes difficult. If there is a minor fire in your surgical unit or your medical unit, and you extinguished it with an extinguisher, you will call it an emergency. It is not a disaster. But if the fire it escalates and becomes a major fire, and you need your fire brigade or somebody to come and help you to put out the fire, then you will call it a disaster. Similarly, if your casualty department gets an influx of around 5% or 10% than your usual census, you will manage it. You will call it an emergency. But if you get 50% or 100% influx, you will call it a disaster, because you will be required to move or mobilize more physicians, more nurses, and more equipment to deal with that surge period. You will call it a disaster. So basically, we call an internal emergency a disaster when your survival without external help becomes difficult or impossible. We call an external emergency, like a road traffic accident or a pandemic, a disaster when it overwhelms your capacity to respond. The responsible overwhelms the capacity of your casualty department or ED to respond to it. Okay, so this is the difference between emergency and disaster in health sector or in a hospital, basically. Now it's very important to understand the 4 phases of disaster management. Sorry for this busy slide, but this is very, very important. These 4 phases are mitigation, preparedness, response, and recovery. Mitigation is similar to prevention, and it involves measures to identify and prevent hazards, both internal and external hazards, from developing into disaster or reduce the impact of the disaster. So here we are actually trying to prevent an incident or prevent a disaster from happening, or minimize the impact of the disaster if it occurs. Okay, and these are some of the examples are HVA, hazard vulnerability analysis, or risk assessment. I will tell you about HVA in another slide. Preparedness talks about it is a state of readiness to respond to emergencies. It involves identifying the resources and backup plans essential to execute the emergency response and recovery operations, which means or the examples are listing down the current and backup plans for your equipment, your supplies, communication, personnel, conducting education, training, drills, etc. Response phase occurs when the disaster strikes. It deals with the manner in which the staff react or respond systematically and effectively to an emergency. Example, notifying the authorities, actions to protect lives and property. Recovery deals with the plan for restoring normality of operations after an incident. So you will be using the recovery checklist. You will do the hot wash. Even after drill, we do the hot wash. Hot wash means what? After the drill or after the real incident, the respondents and the team meets and reviews what went right and what went wrong. Then you make your action plan. You make your after action report, AAR, the after action review. Okay, so that's part of the recovery. Now, it's very important to have a disaster preparedness committee in your hospital, and it will have multidisciplinary team. So you will have representative from admin, medicine, nursing, emergency department, security, health and safety, facility, pharmacy, laboratory, radiology, support services, volunteer services, etc. And some of the factors that the disaster preparedness committee would be considering is when they develop the emergency operations plan. The disaster preparedness committee will be responsible for conducting the HVA, the hazard vulnerability analysis on an annual basis, and also developing the emergency operations plan, the business continuity plan, surge capacity plans, and the functional annexes for your codes, your code red plan, your code brown plan, and all the code plans. Okay, so some of the common factors that they need to consider is the uncertainty. In case of a disaster, this is what generally happens. In the initial period, there will be a lot of uncertainties. You won't be knowing how many casualties are coming, what is happening in the site. Casualty arrival would be a challenge. Some might come by air ambulance, some will come by road, some will show up, like walk-in. So there will be a lot of uncertainties and confusions. There will be issues with the communication with the incident scene. You may not have the right person in the incident scene. Patient care capacity, your system may be overloaded, or your hospital may be already full. You may not have bed. So whom to discharge? You go for the elective discharge or rapid triage or rapid discharge, and cancellation of elective surgeries. So initially there will be a lot of chaos. Staffing may be issues. You might have issues with PPE, contamination, prophylaxis, laboratory support, media relations, morgue, the mortuary. Now the world has run out. Most countries, or some countries, have run out of mortuaries recently. So these are some of the challenges: utilities, supplies, blood products, medical equipment. So these are some of the challenges or some of the issues that the disaster preparedness committee need to consider when they make the emergency operations plan and business continuity plans. Now, when we talk about the emergency operations plan, we need to understand the purpose of this plan. It is to document and communicate the emergency procedures, and it is designed to manage any emergency that might have an adverse impact. Which means this will be an all hazard plan. Most of the EOPs worldwide, they are all hazards plan. That means it will help you to deal with any hazard, any incident, like a fire or a hazmat spill or a workplace violence or a power failure. Okay, and it will also address the 4 phases of disaster management, and it will also ideally provide a framework for your hospital incident command system, the HICS. It will also have contingency plan for emergencies called functional annexes. So it will talk about your fire plan, your code red, or hazmat plan code brown, violence plan code white, mass casualty code orange, epidemics utility. So all these plans will be addressed will be part of your emergency operations plan. We'll also have a lot of appendices, which will be the hazard vulnerability analysis, your surge capacity plans, communication strategies, business continuity plans, contamination plans, memorandum of understanding. Now, it is very important to have MOU with your stakeholders, especially your suppliers. It's called MAP, Mutual Aid Pact. In the West, it is called MAP. But it is very important to have this kind of memorandum of understanding so that all your stakeholders understand your requirements, okay, when you are in a crisis. Now, let me give you a quick overview of the hazard vulnerability analysis. As I mentioned before, this is an exercise done to identify to see how vulnerable you are to a particular disaster situations. So here, you are trying to identify the disaster situations that can strike the hospital. Okay, and you see how prepared you are. You will look at the probability of that incident happening. You will see how it is going to affect your facility, how prepared you are. When you do after this exercise, you will get a score. If you are well prepared, your score will be low. If you are ill prepared, your score will be high. And generally, most of the hospitals use a tool called Kaiser Permanent. Sorry, I could not give you the data here because it was a bit confidential, but I can explain to you the process. So this tool called Kaiser Permanent, it classifies the emergencies or disaster situations into 4 categories. Okay, they are natural hazards, technological hazards, human hazards, and hazmat hazards. Okay, let me give you one example. Look at the natural hazards, for example. Item number 13 here, you can see earthquake. Okay, when you do your HVA to see if your hospital, to see how vulnerable your hospital is to earthquake, you will look at the probability of the incident. You will look at the probability of an earthquake happening in your area, which means you will look at the history, how many earthquakes you had in the last 2 decades. You will also see the identified risk, if any. Maybe if your area is in the seismic zone, the seismic activity, you can get that information from the meteorological department. Okay, so with all these, you will identify the probability of an incident happening. Then you will say whether you are at low risk, moderate, or high risk, and you will give a score. Okay, you will also look at your the impact on the human beings, your property, your business, and also you will see how well prepared you are. Now, in Japan, most of there is a building code mandating that your buildings need to be earthquake resistant or proof. So if you are well prepared, your score will be low. You will enter that score and you will get a clear answer. Now look at Mukesh Ambani's house. I heard that it can withstand a tremor of around 8.2 magnitude. Okay, so if your building is constructed in such a way, then you will be at low risk. Okay, so this is how it goes. So here you will look at the HVA. When you do the HVA, you will look at the your probability, your impact, and then your level of preparedness. You will do the same exercise for technological hazards like electrical failure, generator failure, transportation failure, communication, medical gas failure, HVAC failure, internal fire or internal flood, etc. When it comes to the human hazards, you will see the chance of an infant abduction. Now, some of the hospitals have anti-infant abduction tag, which means, when, for example, when you steal an item from a shopping mall, what will happen? The moment you cross the gate, they will get an alarm, right? Okay, same system, but since we are dealing with human beings in the hospital, we cannot apply that same system. Okay, what you use in the shopping centers. And also, one thing that you need to consider is we may have to give some waivers. Your patient might go for MRI, or the patient might go to the X-ray. So, and sometimes when the mother and the babies are involved, you need to tie the mother, the baby, and the hospital. So it is more complicated. Okay, so you may have to have anti-infant abduction tag. So if you don't have the tag, then you might say, depending on the number of incidents that you consider, maybe you will say that you are at a high risk because you don't have that provision. You will also look at the hazmat incident. I'm not going through the details of this, but this gives you a general idea how the HVA is done. Now, once the HVA is completed by the Disaster Preparedness Committee, you will also develop an action plan and you identify the most threatening hazards. Say, for example, you said that one of the hazards that you identified was mass casualty hazmat incident, like CBRN. Your action plan, your action plan would be to provide or a provision of decontamination facilities in your area. And what are the resources required? You might need budget and space. So you will say who is responsible, and you will also state the time. Now, this is very important. In risk management, you need to give a tentative time by when this incident, this action should be fixed. Okay. Infant abduction, if you have, your recommendation might be to have provision of anti-infant abduction tag, and you will also require budget. You will also give a senior management a time that this is when it is required. Supply shortage, you might recommend that you come to an agreement or develop a memorandum of understanding with your local supplier, and you will assign responsibility to the director of your supply chain. And you will also assign a date for completion. Now, surge capacity plan and 3S. Now, this is very important. When your system is overwhelmed, you will require resources. And what are those resources to deal with the surge? They are staff, and structure. So there might be challenges with staff. Now, adequate number of persons may not be available. Persons with expertise may not be available. Certain number of staff may not be able to join. You may have to have staff recall program. When the staff members are recalled, you need to ensure that they have a staff pool to report to. Where will the physicians report? Where will the nurses report? Okay, so you need to identify your staff pool areas. Then emergency credentialing of volunteers. Some of the volunteers might show up, but they may not have the right license. Okay, so you need to have an emergency credentialing program for the volunteers. You will discuss about, you will think about the stuff, which means the equipment, the bed, pharmaceutical, blood units. Okay, you will consider your disaster trolleys and your disaster material, all your provisions, and the structure. When it comes to structure, you will think of shelter in place and alternate care sites. Now, what does shelter in place? When a particular area in your building is unsafe, you move your patients to another safe location. That is shelter in place, which means movement within the building, shelter in place. Okay. Now, when you make your shelter in place, you need to make sure that you are identifying an alternate location which has the capabilities. For example, you are moving your patients from the medical unit, and if you move them to another area, that area should also have the provisions like maybe oxygen or suction or whatever dependencies they were on. And another important that you need to consider is it should be a fire compartment, because fire is one of the most common emergencies in healthcare. So if you make a plan for shelter in place, then it should be in another fire compartment. If it is in the same compartment, you might have smoke, and then you have to evacuate that place also. Okay, so when you make your shelter in place plan, you make sure that it is done. You identify other fire compartments. You will also think of alternate care sites. Now, when it comes to alternate care sites, why you need alternate care sites? Maybe your hospital building itself is unsafe. Okay, there are 3 types of evacuation: horizontal evacuation, vertical evacuation and total evacuation. Horizontal evacuation is done when a particular area in your hospital is unsafe and you move to another location on the same floor. That is a horizontal evacuation. Vertical evacuation is done when a particular floor is unsafe, you move to another floor. That is the vertical evacuation. Total evacuation means when the entire building is unsafe, you move all your patients, you evacuate the whole building, and then you move to alternate care site. As I mentioned before, there are internal and external emergencies that can strike the hospital. Internal emergencies could be fire, hazmat spill, infant abduction, MRI accidents, or violence. External emergencies could be mass casualty incident like a road traffic accident, major fire or explosion, or terrorism or epidemics. Most of the hospitals have a color-coded system to deal with emergencies. These are some of the codes used in a hospital in India. Actually, we have more codes. I didn't have the right authority to share the codes. We have more codes, but this is how it goes generally. Code red is fire, code orange is external disaster, code green is evacuation, code silver is active shooter, and this is how it goes. And you will also have a particular number to dial. Now there are two levels of emergencies, level 1 and level 2. Level 1 is an emergency and level 2 is a disaster. So what happens when you call your operator, your hospital operator or the call center when you deal with an emergency in your unit? Now, what I'm sharing with you is the practice followed in most of the Western countries and the developed countries. So you may not have the same system, but with my experience both in India and abroad, I feel that this is a very good system. Because it follows the Higgs protocol, the hospital incident command system, and it is very good. Okay, so what happens is generally when you have an incident in your area, you will call 9999 or the number that is assigned. You will call the call center, and the call center or your operator will immediately alert 5 positions. Okay, generally 5 positions. And who are they? They will be the nursing supervisor, the safety officer on call, your security shift in charge, the chief administrator or the on-call administrator, and the technical specialist. The technical specialist varies depending on the type of emergency. If it is a code brown, like a hazmat incident, it will be somebody from the hazmat team. If it is a code gold, like a power failure or water failure, it will be somebody from the maintenance team. If it is a workplace violence related, maybe it will be the PRO. Okay, so this is how it goes. So the technical specialist varies depending on the type of emergency. Now, another thing that we have to consider is whenever we prepare for this kind of disaster, whenever we always plan for the worst case scenario hitting at the worst time. Okay, which means we will always prepare for a Saturday night, okay, or early morning on Sunday when the hospital is running with the least resources. When you have everybody, it is easy to manage. But when you have least resources, that is the difficult time. Okay, so we always prepare for worst case scenario hitting at the worst time. And we always expect the nursing supervisor to take the lead, because nursing supervisor will be the person who has more knowledge about the number of patients, the admissions and the discharge and other resources. Okay, so the nursing supervisor usually leads. I don't know if this is a title used in India, but this is what has happened. This is what is followed in most of the Western countries. Okay, so the nursing supervisor takes the lead. Now, the nursing supervisor and the team goes to the site in case of a level 1 incident, an emergency. They will try to fix the issue. If they can't, what they will do, the nursing supervisor will call the exchange or your call center back and tell them to activate level 2 cascade, which is a disaster situation. Now, in a disaster situation, your call center will immediately call 5 people, or they will immediately summon 5 people who will come to the incident command center. Okay, you will have an incident command center in your hospital, and they will come and join the incident command center within 10 minutes or 15 minutes. It is up to you to set that time frame. But within 10-15 minutes, they will come. Now, in addition to these five persons, the call center will also notify around 40 to 50 persons who will assume these 15 Higgs positions in your incident command center. Okay, so all of them won't come to the command center. It is not required. Okay, but at least these 5 persons need to come to the command center. but others will be notified. They will be standby. Okay, it is up to the incident commander to summon or call whoever is necessary. Okay, but they will be standby. This is how a typical incident command center looks. So in the incident command center, you will have a lot of provisions to help the incumbents to deal with the disaster situation. You will have Higgs identification vest for all the command positions. You will have walkie-talkie, tetraphone, and other communication devices. You will have hotlines, which means what? The hotline you just pick up, you don't have to dial. Okay, the moment you pick up, it will dial, it will ring in the destination. You will also have Higgs folders, the hospital incident command system folders that will contain all your job action sheet for the incident command staff, your Higgs forms. There are many Higgs forms. I'm going to tell you a little bit about it. Then your telephone directory or your communication program. So Higgs will be fully equipped to help you to deal with a disaster situation. It will also have the maps and charts. Okay, because it is important to have the hospital drawing, the charts that will help you to make decision. You will also have the Higgs boards where the incident commander can write the objectives and share with the team, because there are incident objectives that the incident commander needs to set. Okay, the goals. You will also have volunteer badges and many other resources which are required to run the command center. Okay, your incident commands. This is actually a typical Higgs hierarchy. You will have the incident commander. Then there will be a public information officer who will be responsible for sharing information to the media. You will have a liaison officer who will be dealing with other stakeholders like the military or the police or your Red Crescent, Red Cross, or whoever. You will have a safety officer who will be responsible for ensuring safety in the site and the safety of the respondents. So the safety officer will communicate with the incident commander and give a lot of inputs. You will also have a medical technical specialist to tell you about the triage and all the patients programs or whatever is happening with the patients. You will also have an operations section chief. Operations section chief will be responsible for the operations. Your planning section chief will identify the risks. They will make a lot of plans about moving the hospital or moving to another building. Your logistics section chief will ensure that you have adequate supply. Your finance section chief will ensure that there is finance and other resources. So this is how it goes. And the staging manager, a very important position. Staging manager, generally this position is taken over by the nursing supervisor at a later stage. But what we need to understand is, generally when the command center is opened initially, it will be the nursing supervisor, because he or she is the first respondent, right? He or she will be coming to the command center and opening the command center. He or she will wear the incident commander jacket and assume the role of incident commander. When the incident commander, actual admin on call or whoever comes, he or she will hand over that vest to the actual incumbent. Then he or she will assume the duty of operations section chief. When the operations section chief come, like maybe director of nursing or medical officer, when they come, the operations section chief come, again they will hand over the vest and assume the role of staging manager. So what I'm trying to say is, the role in the incident command center, it also changes. Okay, now it is very important to understand the likely positions, the likely incumbents in the command center. As I mentioned, you have incident commander, you have a planning section chief, you have logistics section chief, finance chief, but who are they? You need to identify them. You need to identify at least 3 people to play this role. Okay, you need at least 3 persons who can assume the role of incident commander, because 1 or 2 may be on vacation when there is a real incident happening. Okay, so you need to have 3 persons, and all of them need to be aware. They need to be trained. Okay, all of them need to be trained. So for all these positions on the left side, you will have at least 3 incumbents, and you will train all of them. So what is the role of incident commander? The incident commander will establish incident objectives. So what could be the incident objective? Maybe decontamination of 200 casualties in 2 hours. Okay, this could be an incident objective. Okay, also he will review the scene risk assessment. In the scene, you might have a lot of problem. You might have falling debris. You might have contaminated patients. You might have ongoing explosions. So it is very important to understand what's happening in the scene, and you would have a good communication with the from the incident scene. You will the incident commander will assign HICS responsibilities, will provide periodic update to the executive team, the hospital management, notify the local authorities like your fire brigade or your government agencies, allocate appropriate resources to maintain the critical function, ensure that the incident location is safe prior to authorizing the return of staff or patients. Complete the business recovery checklist prior to ordering order all clear in close coordination with the incident scene, alert all stakeholders once all clear is announced. So these are some of the responsibilities of the incident commander. Now, one thing that we all need to understand is the incident commander will be making decision based on the inputs that he gets from the field. Now, I have been an observer or an assessor or evaluator for the disaster drills and some real events. Now, in my experience, the first 20 to 30 minutes in the incident command center is always a chaos. Okay, you will have a lot of people coming in, you will have different communication, you will get wrong message, you will get wrong number of casualties, wrong location, wrong type of incident, and some of your first respondents might be injured. Okay, so there are a lot of chaos, especially in the first half an hour. So it's very important to give the right message to the incident commander. So when you are calling from a field, from an incident scene, you need to use this. It is good if you use this acronym, which I liked personally, methane. Okay, so what does that mean? You will say whether it is a major incident, and you will also talk about the exact location, which will help the respondents to arrive safely. If you have GPS, okay, send them the location. Now we have a lot of technological help, so you can send them the location. So exact location, then the type of incident, whether it is a fire or a hazmat incident or whatever. The hazards present, maybe ongoing explosions, or you have casualties, or you might have falling debris. You need to inform the incident commander about it. Then the access route, maybe the road on the east side is blocked now with a fallen tree. So you will tell them, okay, now the road on the east side is blocked, so you come through the road on the west side, right? Then number, type, and severity of the casualties, then the emergency services present and those required. Sometimes you will have your Red Crescent and your civil defense or military or police, all the authorities showing up. So you need to tell them what are the services present and what is needed. So methane, major incident, exact location, type of incident, hazards present, access routes, number and type or severity of casualties, emergency services. Very, very important, methane. Now, the incident commander will also require a lot of inputs from the hospital, from within the hospital, to make right decision. And we use HICS forms, the hospital incident command system forms, to enable this. So what are the requirements? I have quoted a few HICS forms here. HICS form 202 and 261. What are the requirements? That will talk about the information regarding hazards, the PPEs, the escape routes. HICS form 205 will talk about the operational status of your communication system, your nurse call system, your paging system, whether it is working or not, your fax, IT system, telephones. HICS 251 will talk about your the status of your operational facility. Also the operational status of your facility, like negative pressure, your electricity, water, heating, ventilation and air conditioning, your sterilizers, elevators, the lift, if it is working or not, your medical gas, vacuum, fire detection system, etc. HICS 259 will talk about your bed capacity, patients triaged, admitted, discharged, transferred or deceased. The HICS 252 will talk about your personal timesheet, the total hours spent by the staff. Then you can also have your own checklist, like recovery checklist or business continuity checklist and other checklists. Now, this is very important, the triage categories. Some of you might be aware of this already, but it's worth mentioning. In disaster, as I mentioned earlier, we triage them, and it is very important. Red tag is usually for those who are requiring immediate care, like life-threatening care, and which means if they are not attended to, they will die. Okay, so immediate and life-threatening. Yellow tag, immediate but serious but non-life-threatening. Okay, like a fracture or something. They are serious but can wait for a while. Green is walking wounded, and black dead. Okay, this is how with triage. Now, let me give you a quick update about the business continuity plan. The aim of the business continuity plan is to promote continuity and rapid recovery of critical functions required to support the core services of the hospital. What we need to understand is, or the difference between your emergency operations plan and the business continuity plan is that your business continuity plan talks about an extended period of disaster, which means you might have an emergency like a fire that lasts for 2 or 3 hours. You might also have a flood that lasts for 2 weeks. You might also have an epidemic that lasts for maybe 6 months or maybe a year now. So in your business continuity plan, you will talk about an extended period of disaster, not just the emergency operations plan. EOP is something kind of like a small scale, but your BCP, business continuity plan, will talk about a long-term disaster that that might compromise your business continuity, right? So these are some of the steps in developing your business continuity plan. What you need to do is you need to list down the key functions and sub-functions in your area. Identify the functions that can be suspended and the ones that need to continue. Now, what happens is, in case of an extended period of disaster, you might be running out of resources and you have to manage your hospital with least resources. What does that mean? When you have limited resources, you might think that, okay, we will close the dental service, or we will close the physiotherapy, the rehabilitation service, okay, and we will invest that resources. We will invest those resources in the operation theater or maybe ICU, which are critical. Okay, so this is the idea. You identify the functions that can be suspended and that need to continue. Now, when you say that, okay, dental service can be suspended, there may be some sub functions that need to continue. Okay, then you will identify the resources required to continue those essential services. Then you will develop your departmental and organizational BCP and communicate the plan and implement. Now, the BCP or the business continuity plan or the development of the BCP needs to be preceded by something called a business impact analysis. Now, in a business impact analysis, you will consider the services or the core functions or the sub functions of your process of your particular department. Then you will identify what tier. Okay, like we say 3-tier AC or 2-tier AC, right? In the train. Similarly, there is a tier system. Okay, so we'll identify the tier, or that depends on the recovery time objective. For example, some incidents, some services or some functions, you will say you cannot compromise, and it needs to be restored within 2 hours. Okay, that is your recovery time objective. So, for example, the engineering department or the facility department, these are your functions. Okay, your critical functions. Okay, and sub functions. You have incident response, you have utility management, electromechanical services, renovation project, design, construction, corrective maintenance, preventive maintenance, etc. Now, you don't want all these services to be restored because there are resource constraints. So you will prioritize. How will you prioritize? You will also have a recovery time objective, RTO. RTO will say, okay, your incident response or your utility management or your electromechanical services, they need to be restored within 2 hours. You can within 0 to 2 hours. You cannot compromise on that because there will be other departments which are dependent on you, right? So this will fall under priority 1, okay, or tier 1. Okay, then you will also have some other services like preventive maintenance, which will fall in tier 2. You will say, okay, we can wait for 12 hours. And some other services, maybe we can wait for 3 days. Okay, so this is how you plan. You will also identify the critical resources required to maintain. Now, you know that in 2 hours, which all departments or which all function need to continue. Then you will look at your resources. Okay, now on a normal level, see, look at the computers or look at the phones here. You have, on a normal day, any given time, you have 25 computers and 25 phones. But during an extended period of a disaster, you will say in 2 hours, that is in tier 1, you need only 2 telephones instead of 25. For Up to 3 days or up to 24 hours, you need only two telephones. But on day 3, you might need 3. Okay, and day 7, you might need 7. Okay, this is how it goes. This is how you go. Right. Then you will also identify the technology and equipment requirement. You will talk about your information management system, your electronic attendance, the staff attendance. So you will say that, okay, the staff attendance, I don't care. In an extended period of disaster situation, you don't care about the staff electronic attendance. Okay, so that can wait. You will also identify the staff position. On a normal day, you might have 6 engineers. Okay, but in a disaster situation or in a business continuity situation, you might say that, okay, I can run with 1 engineer for time being. Okay, for 2 days. After that, I'll think of maybe getting another engineer. Okay, so this is how it goes. Now, always remember, by failing to prepare, you are preparing to fail. Okay, so now I'll quickly give you an overview about the occupational health and safety management system here in the UAE. As I mentioned before, OSHMS or OSHAD is a regulatory requirement. It is a legislation passed by the government of Abu Dhabi. And as of now, this law is limited to the Emirate of Abu Dhabi. It is not applicable in Dubai, Sharjah, or other Emirates. Okay, this law aims to integrate and regulate the health and safety programs in all sectors in the Emirate of Abu Dhabi. Okay, and the integration of these components allow the business to achieve its objectives by managing its impacts on the environment and minimizing occupational health and safety risks. This is a program similar to OSHA, the American OSHA, or the Health and Safety at Work Act in the UK, HASWA. But this is not a copy of OSHA or HASWA. This is a very bold and ambitious program initiated by the government of Abu Dhabi. As you know, Abu Dhabi is regarded as one of the safest cities in the world. And it is not an accident. The government does a lot of things to ensure that they are actually one of the best. So this is how this law is enforced. It comes from the Executive Council, from the ministry, and is enforced through an agency called OSHAD. And then it is cascaded through to the entities through the sector regulatory authority. As I mentioned, this is applicable to all sectors like energy sector, tourism sector, health sector, transport sector, waste sector, education sector, etc. Now, since we are in health sector, we report to the Department of Health. Okay, it is applicable. This law is applicable to all hospitals, clinics, pharmacies, and medical laboratories. This is not a copy of the American OSHA. Now, one of the differences between even the OSHA and the OSHAD here, or OSHMS here in UAE or Abu Dhabi, is that this is mandatory. As you know, even the American OSHA has a VPP, something called Voluntary Protection Program, but here this is mandatory. Okay, and it stems from 4 ISO standards: ISO 9001 Quality Management System, Occupational Health and Safety Assessment Series, or ISO 45000 as it is called now, ISO 14001 Environment Management System, ISO 31000 Risk Management. Okay, so this law stems from these standards. So what are the requirements? There are regulatory frameworks, there are regulatory instruments and guidelines. So there are 9 elements, 55 codes of practice, 12 mechanisms, all these are mandatory. Technical guidelines are optional. So what are the key components in the health sector? In the health sector, it talks about anything that you can think of. It talks about risk management, which risk management is one of the first priorities. So it talks about risk management, disaster, emergency and disaster management, management of contractors, hazardous material management, waste management, occupational safety, occupational health, infection prevention and control, workplace wellness program, etc. Now there are 2 types of entities: high risk entities and low risk entities, or high, medium and low risk entities. The requirements for medium and low risk entities are actually very minimal. For medium entities, it is incident reporting, maintaining a hazmat register, and maintaining a training register, PPEs, etc. But when it comes to a high risk entity like a hospital of ours, there are a lot of requirements. You need to have an OSH committee, you need to have a management review committee, you need to have trained internal audit team, you need to have at least 1 A grade practitioner. You need to have other registered practitioners as well. Okay, maybe B or C, but you need to have one A grade practitioner. You need to have a trained investigation team also. Then you need to develop your manuals and SOPs, legal compliance, risk assessments, quarterly performance reports, management of change, internal audits, third-party audits. So there are a lot of requirements, a lot of documentation. When the auditors come, they will see, and there is an annual audit, and it is mandatory to have one third-party audit annually, one third-party audit manually. Okay, so it's a very robust program. I'll conclude by reminding you about the roles and responsibilities of all employees in health sector mandated by the OSHAD. All employees are required to report incidents. They are required to report unsafe conditions. They are expected to respond to emergencies, adhering to no smoking policy, safely storing, handling, and disposing hazardous material, taking reasonable care of self and others, wearing appropriate PPEs, participating in fire drills and disaster drills and other training sessions, adhering to management of change policies. With a quick reminder, I'll wind up saying that safety is everyone's responsibility, and with a good proactive risk management program, we can reduce the number of incidents in healthcare and ensure that our patients are in safe hands. Thank you, everyone, for listening.
Thank you, sir. The entire presentation is very informative and very elaborate, as well as informative in nature. We should take further questions from the participants.
Aradhana, your voice is...
Thank you. Thank you, Aradhana.
Dr. Chandrasekharan, thank you so much. It was really very, very informative, and a lot of participants have also, sent messages regarding the same. Can we take a couple of questions?
Sure.
All right, sir.
Thank you, Dr. Sushma, and thank you, Aradhana.
So there's one question where the participant wishes to know, what do you think, from your perspective, hospitals have fared during the COVID situation? What's your assessment or take on that?
About the COVID management?
Yes, sir.
Okay, a good question. Actually, a lot of hospitals, there was a competition organized by an organization called CAHO, Consortium of Accredited Hospitals in India, accredited healthcare organization. I joined that institution recently, and I'm sure there are some members from that organization here today. They have conducted a competition about how the hospitals have managed this pandemic, and we also have submitted our activities. A few things that we have done, as I mentioned before, is that is doing a proactive risk assessment. Proactive risk assessment for the tents, for the alternate care sites. So that talks about the your fire safety, the infrastructure safety, and the provision for hand hygiene, and remote working or remote monitoring of the patient. From CAHO, we also learned that there were organizations using Bluetooth, like telescope, stethoscope or something. So there were a lot of innovative ideas that have come up during this COVID pandemic.
All right, sir. So what is your take on the primary health scenario in our country?
So sorry, what is that?
The primary health services, if you would like to comment on that.
Oh, the primary health service. I think the primary health service, if you're asking about India, they will qualify to be like low risk entities here, as per the OSHAD. So low risk entities, I think, or the primary health services, at least you should have some programs for your hazardous material, your training, and incident reporting and investigation, and risk assessment and management. At least these four components. Risk assessment and management is very important. You identify the issues proactively. At least one person. I don't know the size of the primary health centers in India, but at least you should have maybe 3-4 persons going for some kind of training to ensure that you understand how these risks can be proactively managed. You might look at your hazardous because you might be using some hazardous material. You will have risks related to fire safety. You might have equipments. I'm sure you'll have equipments. So all these risks need to be identified proactively and managed. So I think risk assessment, your fire safety of hazardous material, training, and some kind of emergency preparedness, because the expectation as far as the emergency and disaster preparedness is concerned, I think one of the expectations from the primary health center would be to stabilize and evacuate. Okay, I don't think there will be an expectation to manage the casualties there. So your expectation would be basically to stabilize and then evacuate to another facility where there is an advanced care available. So I think you should prepare for that.
All right, so thank you, sir. One more question.
Thank you.
I'll just rephrase what the participant has said. So if you look at Indian scenario, we have primary healthcare centers, secondary, and then you have government hospitals, then you have private ones, and they all have facilities of different natures, in terms of infrastructure, manpower, and all. What can be your comment on, taking care of the vulnerable sections when it comes to dealing at these different levels? I mean, in terms of how the hospital facilities are.
Thank you, Dr. Sushma. This is a very important question. Actually, one of the challenges or some of the constraints in the health sector regarding health and safety is that we have very voluntary participation for most of the best standards. For example, there are Joint Commission standards, there are NABH standards, which are actually more focused on health sector. But how many hospitals opt for this? This is a challenge. Now, some of the private hospitals which are well funded and have who have good infrastructure might go for accreditations. But in my experience, even most of the government hospitals have not gone for these kind of accreditation. I don't know. It's just my view. Correct me if I'm wrong. But I think even our government hospitals that serve a large chunk of our population needs to have more infrastructure. They need to go for accreditation. Now, see, here in Dubai, what they have done is Dubai government mandated all hospitals to go for Joint Commission by 2021. All hospitals. Okay, so this is in addition to your regulatory compliance. Okay, but in India, I think we look at regulatory compliance and the regulators are okay, we are okay. So that shouldn't be the case. The reactive approach to safety, this is another constraint. And when it comes to implementation of any standard, actually I did my research on a similar topic, so I might need a lot of time to talk about it. There are 10 critical success factors that determine the success of these programs. So it starts from the senior management commitment. So your senior management commitment, training and awareness, right enforcement scheme, communication consultation, resources, KPIs, development of your KPIs, your organizational culture, they all matter. Okay, I think primarily resource would be a constraint in some of our government hospitals. But I think it should first start with the commitment. Don't wait for an incident to happen. Okay, I think we all need to think proactively.
Yes, sir. Thank you so much. And any participant would like to, share any experience or ask any question to the esteemed speaker, you're free to do so.
Good evening, sir. Dr. Suleiman Chandrasekharan, sir.
Good evening, sir.
Sir, if you understand, I want to tell you something. This presentation, sir, was remarkable. It is very fabulous. And आपने समंदर को कूजे में कर दिया. Means entire ocean in a vessel.
Oh, thank you, sir. Thank you, sir. It's a very huge topic, actually. And as I mentioned in the beginning, we conduct workshops that last for days. But in 1 hour or 1.5 hours to cover this is actually difficult because we usually apply adult learning principle and we conduct make scenarios for the people to understand. Yeah, thank you, sir.
Sir, I work in a university, sir.
Okay.
Maulana Azad National Urdu University. It is at Hyderabad. I was while we were preparing for the convocation, wherein the expected the participants are thousands in number. So I was in the medical team, though I am not a medical doctor or something, but a few of the officers were selected in medical team. At that time, we had planned for how the event is going to be organized and what are the risk factors, everything, and we have called the ambulance and all those things. So I can remember any event, there may be risk may come in what way we don't know, but all the departments, say for example, our university, we are having a large number of students in different departments. A small health center cannot cater the needs of the entire university. Hence, you have said one thing: incident reporter. Incident has to be reported, and all the staff members. I mean, I came to a conclusion that at least 2 employees in each building should be well trained to guide the people in time of risk and in any disasters. So I think every university and every institutions need such a training. And what I had accumulated from your this session, sir, I am very much interested to do this course from disaster management institution, and I am very happy, and I would like to congratulate you that you are on such a respectable position at Dubai, and in near future also in India, everywhere we will see such type of setup and process for risk management or disaster management. Thank you very much, sir.
Thank you, sir.
Thank you, Zahid ji. One more participant wishes to ask a question.
Yeah.
Please
Hi.
go ahead.
Good evening, sir, and good evening to team NIDM. I'm Sardar Ramiz from Kashmir. A warm welcome to Sir Solomon Chandrasekaran, and I have just 2 points to make, and actually 2 questions. Number first, what is there for India to learn? If you can just tell us what 3 things Indian healthcare system can learn from your experience in UAE and experience throughout the world. And number second is that is the expenditure made during the COVID or any disaster auditable, and to what extent a public, a common man can ask for such expenditure to know actually the veracity of expenditure or how it has been spent. Thank you so much.
Thank you, sir. Thank you for joining from Kashmir. I'm very happy to see you. Both the questions are actually quite relevant, and it's very interesting questions. The first one, what India can do. I think first thing that we need to, from my experience, maybe I'm wrong, we need to stop the blame culture. Because in incident, one of the things that my superiors in the armed forces used to say that in a war and disaster, you will always learn something new. And there is no point in blaming anybody for it. What happens in India, in my understanding, is that whenever there is an incident, you have a lot of media discussion, you have a channel discussion, then a lot of hues and cries about it. But after sometimes when the media get another breaking news, everyone forgets about this. I can tell you my own experience. I am from Alleppey in Kerala. There was a massive explosion during one of the fireworks in a temple in Kollam. You might have heard about it. It was a couple of years back, a few years back. So what happened was, the fireworks were actually not permitted by the district collector, first of all, but some of the politicians apparently bypassed. They bypassed and they got some kind of approval, not written but verbal approval. So there was a kind of major explosion. Around 200, as I recall, around 200 people died. And most of the casualties were rushed to the nearby hospital in Kollam. Okay, and the Kollam hospital was not prepared. And most of the casualties were moved from Kollam hospital to Trivandrum. Trivandrum is the capital city of the state. Even Trivandrum hospital was not prepared. What happened was many casualties, as I read from the next day's newspaper, around 35 patients were waiting outside the operation theater. This means that they didn't have the right communication process. They didn't have the right, plan. that hospital, the Trivandrum hospital, which is a major hospital, never had a disaster drill. They didn't have the right disaster plan. Now see, what we need to do is we need to make sure that your disaster plans are developed and the plans are tested. Virat Kohli or Dhoni and the team will not go for cricket. They will not go for a cricket match without doing some kind of practice, right? So the more you practice, the less will be the errors. So I think what the Indian hospitals need to do is we need to make sure that you have somebody assigned a full-time job. It is not just part-time won't work. We tried with this before. Part-time doesn't work. You have somebody doing this on a like a favor, that doesn't work. You need to have somebody, a full-time person to do this. Then you need to have your policies and plans developed, communicated, trained. Then you need to test, you need to do the drills, test, then prepare after action report, identify the gaps, and then develop your implementation plan, close it, and ensure that you mitigate your after action report is translated into the mitigation plan. And you develop an annual report, and you should have somebody who will be asking for this report on an annual basis. And this is what happens here. It's a huge topic, and thank you, sir. It's a very, very interesting topic. In India, I think, yes, we have a lot of opportunities, a lot of areas for improvement in relation to no blame policy, developing a safety culture. Safety needs to be in the people's mind. Okay. And what was your second question about audit? Sorry, could you please repeat your second question? Something about the audit and the expenditure. Okay, expenditure for the audit. Yes. As I mentioned, you need to have a full-time manager or a full-time employee to do this. But again, it will depend on your organization's vision and the leadership. Now, I'm not blaming in any sector, whether it is private or public, but I think everyone has a responsibility of care. As per NEBOSH, the employer has a duty of care, and I think all the hospitals have a duty of care. The patient doesn't come to you to get harmed, so it is your duty to invest in preventing incidents. I think the hospital, especially the senior management, they need to take it very seriously and invest in prevention.
Thank you so very much.
Welcome, madam.
Yeah. Aradhana?
Am I audible?
Yes, Aradhana.
Since we have come to the end of the webinar session, I would like to address vote of thanks. Firstly, I would like to thank our Executive Director, Major General Manoj Bindal, for his guidance, for his support, and always encouraging us to conduct various webinars. I would also like to thank Professor Anil K. Gupta, who gave a background as well as the backdrop about the webinar session and addressed the inaugural. And the coordinator for the session, we have Dr. Sushma with us. Ma'am was always there helping us with the mails and the list of participants. And the main reason this webinar could come to limelight is because of Dr. Sushma. And definitely I would like to thank our esteemed speaker for the session. We had with us Dr. Chandrasekharan. So your entire presentation was very elaborate. It was so in detail, in depth, and very enlightening for us as well as the participants. And definitely I would like to thank our participants for staying with us since this was an evening webinar session. So we are very thankful to the participants for their time as well as for their patience. Before we end this webinar session, I would like to state that the feedback link as well as the presentation and the YouTube link will be shared to all the participants after the end of the webinar, and it will be shared through their emails. So on this note, I would like to end the webinar. Thank you.
Thank you so much. Thank you, Aradhana, for all the coordination and hard work. Once again, we all take this opportunity to thank Dr. Chandrasekharan, and sir, we look forward to many more maybe collaborations of different natures in the coming times. other endeavors, we can discuss that out separately sometimes. Thank you for joining us. Glad to have you with us, sir. Thank you so much, and thank you all the participants. Be safe. Good evening.
Thank you, ma'am.
Thank you, ma'am. As I said, I'm a veteran. I think it is my duty. I'm a pensioner. It's my duty to do my best for my country, and I'll continue to do it. Thank you for all your coordination and support, and thank you the leadership of NIDM for giving me this opportunity once again. Thank you. Have a good evening, everybody.
Yes, sir. Bye, sir.
Thank you, ma'am.